Hello, everyone. My name is Megan Glenn. I'm the National Assistant Director of Programs at the American Liver Foundation, and I would like to welcome you to today's webinar made possible by the generous support of GenFit and Intercept Pharmaceuticals. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice for patients with liver disease and their families through education, support, research, and advocacy. I would like to thank Dr. Tuan Pham, who will be sharing his expertise on today's webinar, and Dave Frank, who will be sharing his journey as a NASH patient caregiver and advocate. Let's just start with a few housekeeping items. On the upper right-hand part of the screen, you should see a dialog box. If you don't see it, there's an orange arrow you can use to expand the window. From here, you can ask questions. You can ask questions at any time, and we will be answering them all in the last 10 to 15 minutes of the webinar. We will get to as many questions as possible, and we welcome your participation, so please do send questions in. I would now like to introduce Dr. Tuan Pham. Dr. Pham is currently an assistant professor in the Division of Gastroenterology, Hepatology, and Nutrition at the University of Utah. Dr. Pham's clinical practice is largely focused on liver diseases and liver transplant medicine. His clinical and academic interests are especially dedicated to improving the management of NAFLD and nutritional derangements within chronic liver disease, which in turn have naturally extended into the field of obesity medicine. In addition to his hepatology practice, Dr. Pham will be overseeing an endoscopic bariatric clinic, providing a comprehensive, multidisciplinary approach towards weight loss and management of obesity and associated comorbidities. Dr. Pham, I will give you the floor.
Hi, good morning. It's an honor today to speak to you all about a personal passion of mine, non-alcoholic fatty liver disease. I'd like to thank the American Liver Foundation for providing me the opportunity to do so. What I'd like to accomplish throughout the course of my talk is really providing a good overview as far as what non-alcoholic fatty liver disease is, as well as the more aggressive variant of non-alcoholic steatohepatitis, aka NASH. We're going to talk about known risk factors for NASH, and then we're going to talk about how we screen for it and diagnose it, as well as current treatment options. And then I'd like to provide a glimpse into the future as to what we can expect in terms of medical treatments and how else we might talk about treating NASH more comprehensively. All right, so what is NAFLD? Well, it's essentially an acronym for non-alcoholic fatty liver disease, and it encompasses a spectrum of different disease processes and outcomes, but the central hallmark feature here is really fatty infiltration of the liver. How the fat gets into the liver is essentially a question that we're still trying to figure out precisely, but by and large, or really kind of fundamentally, it's related to an imbalance in the way the body manages energy and energy storage, as well as kind of fat in that context. And we, by and large, see that in patients who are overweight, although being overweight is not necessarily a requisite for developing non-alcoholic fatty liver disease. So what does a person with non-alcoholic fatty liver disease potentially expect to get? Well, most of the time, people have just plain simple steatosis, and that's just essentially fat infiltration of the liver. And people who have fatty infiltration of the liver, about 90-95% of people with NAFLD, really just have pretty stable indolent disease. About 1% of these patients might actually go on to develop liver cancer, but by and large, people with simple steatosis, again, which is benign fatty infiltration, don't develop too many problems or complications. About 5 to 10% of these people, though, however, can get NASH, which is a more aggressive variant of the disease. People with NASH can go on to develop scarring, cirrhosis, and with cirrhosis, they are at increased risk for developing decompensation, which just means all of the problems related to very advanced liver disease and problems related with something called portal hypertension. And then a fraction of these patients are actually at an increased risk for developing liver cancer as well. I'd like to point out, based off of this slide, that people with non-alcoholic fatty liver disease not only just develop primary liver-related outcomes or complications, they are also at increased risk for developing cardiovascular disease as well as type 2 diabetes. And we'll talk about what that means here in the next few slides. So this is showing us that people with non-alcoholic fatty liver disease, compared to the general population, have decreased survival over a 16-year span. So over many, many years, but certainly very significant decreased survival rates compared to, again, a general population. And patients or people with NAFLD tend to not survive as well as the general population because of an increased risk for cancer, heart disease, and again, progressive liver disease. But more importantly, people with NAFLD, it's really within that population, people with NASH, the more aggressive version, that are the ones showing us this decreased survival curve. When you're looking at just people with plain fat in their liver, plus with or without nonspecific inflammation associated with that, their survival curve is not necessarily decreased compared to the general population. It's when you actually have NASH that we see that survival curve be affected. It's also important to note that it's not just liver problems that people with NAFLD and NASH get. I've already talked to you about the increased risk for cardiovascular disease, and that's essentially heart disease, as well as type 2 diabetes. But people with NAFLD and NASH are also at risk for developing chronic kidney problems, psoriasis, other types of cancers outside of the liver, osteoporosis. They might have more problems with fat and being able to lose it, and then as well as polycystic ovary syndrome. NAFLD and NASH and diabetes are seen very commonly together in patients, and the relationship between the two is thought to be bidirectional. And what that means is people with NAFLD and NASH are, if they don't have diabetes, they're certainly at an increased risk for developing it over time. If you have diabetes, if you have NAFLD and NASH and obesity or insulin resistance, then your risk for developing diabetes is additive. And then people with NAFLD and NASH have a higher prevalence of diabetes just in general compared to the rest of the population without NAFLD and NASH. And then on the flip side, people with diabetes have the risk for developing more aggressive NAFLD and NASH complications. And so if you have diabetes, and you have a family history of diabetes, then your risk of developing NASH and related problems is higher. You are at increased risk for dying from cirrhosis related to NASH, and all of the different problems related to progressive disease therein. If we were to try to predict who is going to get NASH in a group of patients with NAFLD, there are certain clinical parameters that are pretty helpful to think about. People who are of advanced age are probably more likely to have the more aggressive NASH variant, and that's probably just because they have the disease for a longer time frame. We see that postmenopausal women actually tend to have more aggressive disease compared to men or younger or premenopausal women. Interestingly, we see an increased prevalence of NASH in Hispanic and Asian patients, and decreased prevalence in Black patients. That's not to say that Black patients don't get NASH. It's just, if you were to compare different race populations, they might have statistically less of a chance of having more aggressive disease. People with high blood pressure, obesity, cholesterol derangements, insulin resistance, or overt diabetes are probably more at risk for developing aggressive NASH. And then if you have kind of chronically elevated liver tests, specifically this ALT level, then that's been seen to be associated with potentially increased risk for NASH. With the rising number of obesity as well as diabetes in America as well as the rest of the world, we are projected to see more complications related to NASH over time. This is a graph kind of showing us the rate of progressive liver disease and liver cancer and liver-related deaths in the NAFLD space through the year of 2030. It's really quite a significant expected rise. So with that all said and done, how do we approach a population as far as screening practices? And by screening practices, I mean, what do we do just kind of categorically to screen the population for NAFLD? Currently, based off of our data, there's really no strong recommendation that screening should occur. And that's even in high-risk groups such as people with diabetes, people who are overweight, people with cholesterol problems, aging populations, people with family members. And this is despite all of those things that I've just talked to you about. And that's just because we don't have the test yet to kind of justify, again, application of screening practices to a wide-scale population. That's not to say that you shouldn't have that conversation with your doctor if you have those risks that I've detailed earlier, if you are concerned about having NAFLD and you are concerned about preventing further complications. And so when you are concerned about those things, I do think it's worth talking to your doctor about specifically looking in your case whether or not testing is appropriate. Once you begin that conversation and once your doctor starts kind of that testing route, what does that look like? Well, diagnosing NAFLD involves a few different things. First off, we have to see, we have to see that there's fat in the liver, and that can be seen through either imaging or through a liver biopsy. And we have to exclude other causes of why fat might be in the liver, and that's commonly alcohol, as well as some other causes that I will detail in the next slide. Here. So alcohol, as I mentioned, is a very common cause of fat to infiltrate the liver. Hepatitis C, specifically one of the variants, genotype 3. Certain types of medications, for example, methotrexate. Wilson's disease is a hereditary condition whereby copper gets accumulated into the liver and it causes this fat accumulation. And then parenteral nutrition is essentially where someone requires nutritional support by vein rather than conventional just oral feedings. And then if you have severe malnutrition or if you know someone with severe malnutrition, they might also get fatty infiltration of their liver as well. And that's essentially because the liver is not able to carry on vital metabolic processes and fat accumulates as a result of that. People with NAFLD might actually get, over their lifetime, really no problems, but again, a small number of those patients might actually go on to develop inflammation. If you get inflammation, then you could still regress back to benign kind of indolent fatty infiltration of the liver, or you can still go on to develop progressive scarring and cirrhosis. The movement in that spectrum is bidirectional. It's not just a single track. But if you do develop a single track, it's probably because you have certain modifiers of disease that are predisposing you to developing more aggressive disease. And again, that's if you have obesity, if you have type 2 diabetes, if you are fairly sedentary in your lifestyle and not very physically active, then you might be at risk for developing more kind of singularly progressive disease. And then certain genetic modifiers, which again speak to the idea of certain races and populations or ethnicities, I should say, having higher prevalence of a more aggressive disease compared to others. And then again, age is a factor here. So it's important that when we talk about NASH, that we talk about how to identify people who are at risk for developing that kind of more singular progressive trajectory. And probably the single most reliable predictor, aside from those clinical parameters that I've talked to you about, is if your liver is already showing us damage as a result of the disease process. And by damage, I mean fibrosis or scarring. So if you are found with NAFLD and you are found with scarring and inflammation, then you are probably one of these higher risk patients that we need to watch more closely for all of those different problems that I've spoken to you about. How do we determine if you have scarring and fibrosis in your liver? Labs and imaging can be helpful. Common labs and imaging, that is, can be helpful, but that's really only if you've already progressed to cirrhosis, and at that point it's quite obvious, and that's where those things capture that. Shy of overt cirrhosis, then we need more precise testing. And historically, that's been liver biopsy. Unfortunately, liver biopsies are not without some small risk, including bleeding and damage to surrounding structures. So if we can avoid liver biopsy, then that's something that we're going to try to do. And nowadays, we have testing such as lab-based panels and certain scoring systems kind of derived from common labs that might help the provider or your physician determine if you have accumulated signs of scarring and fibrosis already. Elastography is also modern, kind of newer technology for us to determine if there's fibrosis and scarring in the liver. This can be done through either vibration or magnetic resonance technology. What this essentially entails is the idea that if your liver has fibrosis and scarring, it's going to be progressively stiffer with accumulating more fibrosis and scarring over time. And so what these FibroScan and MRE allows us to do is measure how stiff is your liver and then really kind of show us a spectrum of how much scarring and fibrosis has accumulated as a result over time. So a nice non-invasive way for us to determine if you've already accumulated damage and probably have underlying NASH as opposed to just more benign indolent steatosis or fatty infiltration. Once we make that diagnosis of a patient having NASH, what can we do to start helping reverse that process and ideally prevent those complications such as liver cancer, cirrhosis, progressive liver failure, etc.? By and large, the probably most successful treatment strategy that's been consistently shown to be effective for reversing NAFLD and NASH is weight loss. We see that people who lose more than 5% of their total body weight can decrease the amount of fat content with their liver. If you lose more than 5%, like something more towards 7%, even 10%, then you can actually start seeing improvement in inflammation and fibrosis and scarring. Certainly, losing weight is easier said than done. We all recognize that it's a struggle with many people, and there's lots of different diets out there. There's probably no single diet that is better than the other in terms of just weight loss efforts alone. But what's tried and true is probably if you just reduce the amount of calories that you consume throughout the day, then that's been consistently shown to be very effective in weight loss. And specifically, if you decrease your caloric intake by 30%, which translates to about 750 to 1,000 calories less than what you're currently consuming, then that has been shown to improve your weight loss efforts as well as improve insulin resistance as well as fat content within the liver. I'd like to take a little bit of time to talk about the Mediterranean diet. Mediterranean diet is a strategy that is incorporating dietary choices and principles based off of people living in the Mediterranean region. It is not necessarily meaning that you have to eat Mediterranean food. You're certainly, you should do that if you like that. But what it really means is kind of doing what they do philosophically. And what that means is you're not eating as much red meat. And what I've shown you here is a food pyramid to kind of show you how much you should choose from different categories. Red meat being at the very top. So try to avoid consumption from that bin as much as possible. Maybe decrease it to about once or twice a month. You should get your fat content from things like seafoods, especially fish and olive oil, and those just have certain healthy types of fats. And then you should get your carb intakes from what we call complex carbohydrates, which means grains and things that are take your body longer time to break down as opposed to refined sugars like pastries and breads, etc. Exercise has been shown to improve fatty liver disease. We see that people who at least increase their physical activity by 60 minutes per week, but ideally closer towards 150 minutes per week. And that can be done either through just light cardiovascular activity or resistance training. Then people who do that can have decreased fat content within their liver. And if you increase your exercise to more vigorous levels, then you might actually improve fibrosis as well. And this is independent of any kind of weight loss. So if you don't lose weight, but you're exercising just this amount, then you can make a big difference in your fatty liver disease. Coffee has been seen to improve fatty liver disease. It's currently recommended by the European Liver Society to consider that as part of a lifestyle intervention for modifying progressive fatty liver disease. And what we see scientifically is coffee consumption has been shown to decrease liver fat content, scarring in the liver. In animal models, at least, we see that it can reduce inflammation. Still trying to understand why that is, but there's some thought that maybe it might be an antioxidant effect. And then again, anti-inflammatory might be part of that explanation. Currently, there are no medications that are approved by the FDA for treatment of fatty liver disease. That's not to say that we have not tried looking at secondary use of medications currently already out there. Metformin, which obviously we see in the use of many patients with diabetes, has been looked at specifically for its effect on reducing fatty liver disease. Unfortunately, we don't see much of a benefit there, so it's not currently recommended for treatment of fatty liver disease. Again, if you're diabetic and you need it for that, then by all means do so. But if you think that it's going to help your fatty liver disease, the data is still lacking. Pioglitazone is another diabetic medication. Has actually been shown to improve NASH. Again, that's the more aggressive version of NAFLD. And that's been shown to improve NASH in patients with or without type 2 diabetes. And so if a doctor speaks to you about using that and you don't have diabetes, then don't be surprised. Vitamin E has also been looked at specifically at a dose of 800 units per day. That's been shown to improve NASH, specifically in non-diabetic patients. We don't know what that looks like or the improvement is in diabetic patients. And then if you have more aggressive disease, cirrhosis, liver failure, then we don't know the safety profile there. And then, of course, clinical trials are underway. If you are interested in potentially participating in a clinical trial, make sure you talk to your provider about those kind of options. Just a word about patients who get cirrhosis with as a result of their longstanding NASH. Really, at this point, the medical options are a little bit more on the limited side. We would treat these patients pretty much like any other patients with cirrhosis, whether it be from alcohol or viral hepatitis, et cetera. And what that means is what we're monitoring for complications related to cirrhosis. And so you can get things like hepatic encephalopathy, that's essentially mental status issues related to cirrhosis. You can get varices, which are these enlarged veins in your intestinal tract that are prone for internal bleeding or spontaneous bleeding. You can get ascites, which is fluid accumulation. And so people with more advanced liver disease are at risk for developing these complications. And we watch patients with NASH cirrhosis accordingly so. And then, of course, the point of an increased risk for liver cancer in NASH and NAFLD cannot be underestimated. And so I think that it's important to note that regular screening for liver cancer is absolutely warranted and necessary in patients with NASH cirrhosis. Patients with very advanced cirrhosis as a result of NASH should be considered for liver transplant. And what we see is, as a result of the increasing rise of NASH throughout America and throughout the rest of the world, we see it as a rising indication for liver transplant as well. It used to be that hepatitis C was the number one cause for liver transplant in America. Still the case through 2013, but on the downtrend actually. And NASH is grown in terms of indication up to 170% as the reason why people are getting transplanted in America. Unfortunately, not everyone with NASH qualifies for liver transplant because they have things such as diabetes and heart disease that might be out of control, that might make the surgery unsafe. And so patients with those issues certainly should be considered for transplant, but will need very diligent testing to make sure that they can undergo transplant very safely. And then just to close out this talk, I'd like to give a sense of, or kind of talk about what's more to come. So there's currently multiple medications being looked at for treatment of NASH, specifically looking at trying to reduce the inflammation and scarring related to NASH that eventually lead to cirrhosis and progressive liver failure. Obeticholic acid, which is a medication made by Intercept, is currently in phase 3. It's expected to potentially complete testing by summer of next year. Cenicriviroc, which is made by Allergan, also in phase 3, thought to hopefully complete its testing by October of 2021, and then elafibranor by Genfit, which is also again in phase 3, hopefully will complete testing by December of 2021. All of these medications, like I said, are meant to treat patients with NASH, the more aggressive disease variation, to try to prevent further complications. And then just back to weight loss, I think it's so important that we recognize that NAFLD and NASH are not just liver problems, but can affect your overall risk for heart disease and diabetes and all of the diabetic complications, as well as increase your risk for cancer. That's not just in the liver, but other types of cancers as well, breast cancer, colon cancer, you name it. There's an increasing risk of problems related to being overweight and obese. And so I think it's important that we talk about kind of more aggressive weight loss solutions when we're talking about NASH and all of the different problems related to that. So certainly weight loss surgery has been around for decades now, and we see that it is a safe option, and we see that it's a very effective option for not only weight loss, but we see it effective for treating NASH as well as some of these other problems. Gastric bypass, gastric sleeve, lap band are the most common surgical options right now. Medical weight loss programs should be considered. There's currently 5 medical options approved by the FDA. I've listed them here for you. And then, of course, endoscopic weight loss is the newest kid on the block. Those technologies were approved around 2015. Right now, gastric balloon is probably the most commonly employed device of the endoscopic weight loss solutions. And what that is a balloon that we inflate in your stomach. It's not permanent. It's meant to be in your stomach for 6 months and to kind of kickstart essentially better choices and a whole new kind of weight loss perspective and health perspective in terms of preventing, status quo in terms of your obesity and overweightedness. So I list these things here. I think that it's important that we do these programs in tandem with dietetic support and exercise physiologists. And I think a program, if you are considering these types of solutions, make sure you are considering a very comprehensive program that incorporates those supports that I've talked to you about. And do keep those in mind when you're talking about NASH and weight loss and preventing some of these other complications.
Okay, all right. Thank you very much, Dr. Pham. I would now like to introduce David Frank. David lost his mother to NASH in October 2014. After her unfortunate passing, Dave decided to become an advocate for liver disease patients. He founded NASHaware.com, a blog dedicated to raising awareness for NASH. He serves on the Greater New York Division Board of Directors for the American Liver Foundation, as well as the chair of the Associate Board of Young Professionals at ALF. Dave?
Thank you, Megan. As someone with zero medical expertise outside of my Google skills, I've been fortunate enough to be able to work with great individuals like Dr. Pham on helping raise awareness for NASH. That was a great presentation. It's a hard act to follow, but I will do my best. 6 weeks. That's how quickly Mom went from being diagnosed with NASH to leaving us forever. Just enough time for the survival instincts to kick in, enough time for a family accustomed to failure to execute a plan of attack, to prepare for a transplant, to bring Mom home at a time when we thought a crash diet change and carefully administered medicine would provide a lifeboat to recovery. To learn a modest amount about bilirubin levels and cirrhosis and MELD scores and begin to hope that she could beat it. My name is David Frank, and in October 2014, my mother Geraldine passed away after a very brief and completely unexpected battle with late-stage NASH. She was only 62 years old, and had showed no symptoms until just weeks before being diagnosed. Like most people, my family and I had never even heard of this disease that took her from us. They call NASH the silent killer, and in Mom's case, it was certainly true. She was never diagnosed with any form of liver disease at all before NASH. We had noticed some yellowing of her eyes and convinced her to go to the doctor about a month earlier, but it took time to get an appointment with a specialist who checked her into a hospital upon her visit. She stayed there for a few days of testing and then was released pending the results of a liver biopsy. My family was concerned but optimistic based on the lack of other symptoms. Mom seemed totally fine. Of course, I now know that simply being overweight is one of the most crucial indicators of NASH. A few days later, I received a frantic call in the early hours of the morning from my dad. Something was wrong with Mom. Luckily, I was only a few blocks away and raced over to find her in a dazed and confused state, aimlessly walking in circles and incoherent, a condition I later learned was due to her liver failing and not being able to cleanse dangerous toxins from her blood. She was rushed to a local hospital where the initial diagnosis was not good. The liver biopsy returned later that night and confirmed the initial suspicions. Mom had late-stage NASH that had progressed to severe cirrhosis. There was no treatment. She needed a liver transplant to live. The time frame of my mom's last few weeks really complicated the grieving process for me. It wasn't instant or nearly so like a massive heart attack or a car accident would be. In those terrible scenarios, there was simply no chance to say goodbye, no time for the Kubler-Ross model to kick in, no chance for hope to take root. And yet it was also not as extended and drawn out as someone who was diagnosed with cancer or other deadly diseases that take months or years to steal someone precious from us. No real time for it to sink in, no to come to terms with it, to be as ready as anyone can be to say farewell. As a result, when she suddenly took a turn for the worse in her last few days, it was like the rug being pulled out from under our feet. We'd had our scare, realized how serious the condition was, and put into motion a plan to get Mom out of it. My sister was ready to donate a portion of her own liver to Mom. It was going to be okay, we had told ourselves, until it was not. For a long time afterwards, I struggled with grief, guilt, and a complete feeling of helplessness. I'm the kind of person that takes action, fixes things, and always finds a solution. I don't take no for an answer. For really the first time in my adult life, I'd faced a situation where there was absolutely nothing I could do to help Mom. And so I started looking for things to do to help others. I researched NASH and other liver diseases and learned as much as I could. I found out that over 90 million Americans are afflicted with non-alcoholic fatty liver disease, and that more than a third of them, 30 million people, may have already progressed to NASH, many without even knowing it. I read about NASH becoming the leading cause for adults being placed on liver transplant lists, surpassing hepatitis C. I discovered that globally, nearly a quarter of the entire population of the planet likely has NAFLD. These numbers are simply staggering. Now combine those figures with the 1-2 punch of NASH diagnosis and remedies. Abysmal early detection rates due to a lack of efficient, non-invasive diagnostic methods, and a total lack of any viable treatment for patients that progress to NASH. Like Mom, when you finally figure out that you have a problem, there is nothing you can do about it except hope to be lucky enough to get a transplant. I ultimately decided that I couldn't merely read and learn about the disease that took my mom. I had to actually do something. So I started out volunteering with the great folks at the American Liver Foundation, and now serve on the Greater New York Board of Directors and as chair of their young professionals group known as the Associate Board. We've done some great things together, and more are sure to come. Yet I wanted to do more. I'm a big tech geek, and I waste far too much time online on websites and blogs, and I decided to use some of that energy for good. So I founded NASHaware.com to help raise awareness and educate others. If I can help even a few people, it will be all worth it. But I still want to do much more. The problem is that liver disease has never been a sexy cause. It doesn't get pink campaign deals with the NFL or have movies made about it. And yet, unlike cancer, AIDS, every single person is a potential victim with a disease like NASH. You don't particularly need a genetic disposition or family history. You don't need to have a risky lifestyle. You just need to be overweight for a period of time. It's a preventable health crisis that may soon compete with cancer and heart disease as the leading cause of death for Americans, and yet doesn't get more than a blip in the press. Much of this is due to the fact that liver disease is still strongly associated with the stigma of alcohol use. Even friends and family that we have explained Mom's disease to many times over still can't quite grasp that she was not an alcoholic. That will need to change. We've known about the rising rates of obesity in Western society for nearly my entire life. The World Health Organization declared an obesity epidemic in 1997, over 20 years ago, and the numbers continue to grow at disturbing rates. Last year at the European Congress on Obesity, researchers presented staggering projections that over half of all Americans will be obese by 2045. These people are all potential ticking time bombs at risk for NASH. NASH is known as the silent killer. Much of this is because even in the medical community, awareness of the severity of NASH is far too low. A March 2016 Deerfield survey found that almost half of primary care physicians surveyed were unaware of the clinical differences between NAFLD and NASH. An October 2017 survey by the Chronic Liver Disease Foundation found that 58% of medical doctors were unaware of specific NASH trials currently ongoing. We still have a long way to go. My wife and I found out that we were pregnant with our first child when Mom was in the hospital. I didn't tell her until she was already comatose, and we were desperately hoping that she would fight through it. My daughter now bears my mother's middle name, and being 4 years old is very curious about her Grammy, who she sees in all these pictures, but will never meet. My sincere hope is that by the time she is a grown woman, deaths from NASH will be an odd rarity rather than a steeply increasing pandemic, largely due to the efforts of the many medical professionals, researchers, and investors involved in the race for a treatment and diagnostics. With that, I want to thank the American Liver Foundation for inviting me to share my story with you all, and especially Dr. Pham for his fantastic presentation today. I can write a bunch of words on the internet, but the actions of individuals like Dr. Pham will be the ones that save people like my mom in the future. Thank you.
Thank you very much, Dave. Now we're going to read some questions. I do want to clarify, we can't answer any questions that are specific to your patient history, but we will answer, general questions and things like that. So the first question is there a typical timeline frame or a typical time frame indicating progression of NASH? Dr. Pham, this is for you.
Sure. The problem is the way we've understood NASH historically has always been kind of retrospectively. So someone who comes in usually is because they've already had signs of progressive disease, and so it's caught incidentally. And the issue with liver disease is it can be silent for so long, and so you can have brewing NASH for decades, and if you're not following with your primary care doctor, or someone's not doing testing, generic testing as far as your liver chemistries, then things might not be caught. And even with NASH, your liver enzymes aren't necessarily elevated all the time. And so even if you're doing everything right and you're following with your primary care doctor and they do these annual liver chemistry testings, it might not necessarily capture the full picture. And so right now, the problem with NASH is that we are in an area where how do we detect it earlier on without using kind of the current technology, which is lacking. And so I guess the point of me saying all of this is that you can go for decades without having disease detectable or kind of, declared disease. And again, I showed you that, even if you have fat in the liver, it might go on to inflammation or it might not. And if it does go on to inflammation, it still might regress. And all of these are kind of related to other parameters such as fluctuating weight, physical activity levels, etc. I don't know. Did that answer the question? I think it's really meant to say this disease can take years to manifest, but if you're going to have more aggressive disease, then we are lacking biomarkers right now to kind of show us, other than just coming in with specific questions to say, do I have NASH and am I at risk for developing these problems? And then we start kind of employing second and third line agents. And if you do have NASH, if we do show that you have more aggressive variant, then it kind of depends on how much scarring you have accumulated over time. No person is kind of like the other. If you're a 20-year-old, let's say a 30-year-old with moderate amount of scarring, then you're probably going to develop cirrhosis probably over the next 10 years or so, as opposed to someone who is 60 who comes in with only minimal scarring, then you might not necessarily develop problems at the same rate. So it's varying kind of time courses.
Thank you. Okay, this next question is referring to your slide on associated medical conditions. Is the insinuation that if you have NASH, it can cause psoriasis, sleep apnea, diabetes, or does NASH potentially come after you have those?
No, that slide is meant to show is that there's an increased association. And so nothing in medicine is ever black and white. One causes the other. There's always, this kind of idea that if you have NASH, then you might be also someone with psoriasis. And so the association between psoriasis, or the frequency of psoriasis is seen to be increased in patients with NASH. And maybe it's because of an immune-mediated process or a derangement therein. And the same can be said about some of these other problems. It's more of meant to show you that it's a syndrome of problems. And so if you have NASH, you also probably have other conditions or things that predispose you to these conditions. It's not to say that NASH causes psoriasis or vice versa.
Okay, the connection between NAFLD and NASH and diabetes. This listener just wanted to know if you could clarify between type 1 and type 2 diabetes.
Sure. So type 1 diabetes is what we essentially kind of use as someone whose pancreas no longer makes insulin. And so those cells, beta cells, have been destroyed. And commonly and historically, we've seen that in children because of various reasons, and so that's where kind of type 1 kind of comes from. And then type 2 is someone who develops diabetes as a result of long-standing insulin resistance, and so your pancreas can make insulin, but your body does is not sensitive to the insulin. So that's insulin resistance. And then over time, insulin resistance leads to the pancreas just working itself to death, and then it's no longer able to make insulin. So those cells essentially just kind of kill themselves trying to work themselves so hard making insulin to keep up with that insensitivity. Now, throughout this process, and I point that out just to kind of frame the question or kind of frame the answer a little bit better. NAFLD and NASH are, again, kind of is a disease where you're accumulating fat in the liver as a result of this imbalance in energy homeostasis, or how our body regulates energy and fat storage. And insulin's one of the prime players there. And so if your body is not able to make insulin, then it's probably going to improperly store fat. And if your body is, or, use fat in a meaningful way. And if your body is insensitive to insulin, then the same kind of can be the same issue there. And so type 1 and type 2 essentially can have NAFLD and NASH, and it's really no one is worse than the other at that point. Sorry for the long-winded answer.
Thank you. How much of the projected increase in incidence of NASH is related to or is attributable to better awareness and increased development of better screening methods, and how much would you say is a true increase in incidence due to clinical factors?
I would say that it's mostly due to clinical parameters. And so again, by and large, biggest risk factor for developing NAFLD and then its more aggressive variant NASH is obesity. Again, that's not the only thing that causes it, but by and large, that's what we see most commonly. And what we do have data for is that obesity and diabetes are also on the rise. And so the increased rise in NAFLD and NASH really mirrors that. Now, certainly that's not to say that we don't need better screenings, but I do think that clinical parameters and the health of the population and the change in health perspectives and how we perceive what's acceptable and not is probably one of the biggest drivers here. That's my thought anyways.
Thank you. Okay, we're getting actually a few questions about this topic. The ketogenic diet and also intermediate fasting, would that affect it negatively? People are asking.
No, I think that's a great question. I kind of anticipated that question arising. I'll admit, I'm not a great expert on the content. I have done some research on the matter, though, just because it is something that people are doing, and I am, just curious to see. What I've seen or what I've encountered in my research is that ketogenic and intermittent fasting are both diets that can be effective for weight loss. And I think what the take-home point should be is anything that you can do to decrease weight is really going to improve fat content in the liver and improve insulin sensitivity. And those, again, are the two biggest drivers of disease and disease progression. So if either one of those diet works, then that's going to be the diet that is the one for you. In terms of head-to-head comparison, as far as modifying NAFLD and NASH, that study's not been done, but I do think that you can extrapolate the data to say that if the diet works, then that's the one that works for improving your liver disease. They're two very different diets, though. So so if someone can observe a ketogenic diet but not an intermittent fasting diet, then just do the ketogenic diet and vice versa.
Thank you.
Hopefully that answers the question. I'm happy to take more questions on the matter.
Okay, great. Someone's asking, why isn't hepatic encephalopathy considered in patient care when the patient needs surgical intervention that may worsen the symptoms of HE?
Yeah, so HE is actually a spectrum. And so you can have low-grade HE, and then you can have very severe HE. Low-grade HE is still deserves attention and treatment, and the medications for that are really outpatient medications. And so the current first-line therapies for HE are things that are meant to try to rid the body of the toxins that are now traveling to the brain in more advanced liver disease states. And those medications are pills and things to kind of help mobilize those toxins. And you don't need to be monitored when you're just taking these, oral medications. But in more advanced states, the concern there is not the medication administration. It's because these patients are no longer protecting their airways, and they become more at risk for critical problems and going into a coma and requiring advanced life support to kind of help them get through that. And those are the ones that actually should be hospitalized and should be watched very closely. Liver transplant for treatment of advanced liver disease is certainly part of that discussion, but the problem is there's a lot of people with liver disease for various reasons. Certainly NAFLD is one of the growing indications, as we've discussed, but that means a lot of people are just waiting for liver transplant, and we just don't have enough organs being donated to meet that demand. And unfortunately, in an age where there's increasing overweight and obesity in the population, the livers that are being donated sometimes have a lot of fat in them, and those livers are not acceptable if there's too much fat in the livers. And so the bottom line is people are waiting for transplant. And so even if a person is sick and they're starting to manifest these signs of advanced liver disease, they're still going to have to wait for a while until we can actually get an organ available for them that is suitable. And so that's where the transplant program comes in, is to try to help people, go through this entire process safely and get them across that finish line of getting them to a liver transplant if they are a candidate.
Thank you. This is a two-part question. What about bariatric treatment after transplant to reduce and prevent comorbidities? And the second part is, what about bariatric treatment? Is it considered before transplant as well? So both sides of that.
Yeah, I love that question. That is great thinking, and that's really kind of cutting edge research at this point. The Mayo Clinic has probably been the most experienced in this subject, and I think that what they've looked at is, can a surgery at the time of transplant help reduce some of these post-transplant complications. And so some of these post-transplant complications, and by post-transplant I mean after transplant. So people after transplant are at risk for developing recurrence of their fatty liver disease, and they're, again, at risk for developing the problems associated with fatty liver, such as diabetes, heart disease, et cetera. And so that's a great question. And what the Mayo Clinic has shown that is, in very select patients, that is a good strategy. The problem is it's a very selected or very biased kind of study, in the sense that they were very much, picking only very specific patients for that study. That's not to say it shouldn't be considered, but kind of applying that to broader populations, we don't know that answer yet. And so I think it's an option, and it really kind of depends on the program that the patient is getting transplanted at, if they have that comfort level and expertise in bariatric surgery in a post-transplant patient or in a liver transplant patient, because that becomes a different type of surgery compared to someone who's not had a liver transplant, because there's scarring, there's inflammation, etc. Now, prior to transplant, that's also another great question. Prior to transplant, surgery is felt to be a little risky, quite honestly. People with liver disease who are waiting for a transplant, by definition, are very sick, and things like elective surgeries tend to tip them over the edge. And so if you're trying to get them to transplant so that they can survive and have a good life afterwards, then doing the surgery beforehand might be more than what their body can handle. And so that actually has not been explored. So what's really been looked at is non-surgical weight loss options, such as endoscopic techniques and medications. Endoscopic weight loss surgery prior to transplant the Mayo Clinic did open up a study for that as well, but I don't think that they completed it. And I do know that there's some centers in India also looking at that kind of thing. And so that question is being explored a little bit more scientifically, but it's not really gained some traction just yet. And then medications are something definitely worth considering, and so that's something to potentially talk to your provider about and see if there are resources or programs that incorporate medications and monitoring very safely for weight loss prior to a liver transplant. And might actually be necessary because certain patients who are too large don't necessarily qualify for liver transplant. So if we're trying to get them ready for transplant and to be a candidate, then that might even be a necessary step. Thank you for that question.
We have a few people asking this question in a few different ways. Basically, what are the genetic components of NAFLD-NASH, and are there any factors that kind of increase the risk?
I'm sorry, what was that last part of the question you said, Megan?
Are there any hereditary factors that increase that risk of getting NAFLD-NASH?
Sure. So when we're looking at genetic contributions, there's a few different ways of answering that question. The easiest way of answering that question is there is a gene called PNPLA3 that's been consistently shown to increase your risk for NASH. And so if you have it, then you are at risk for developing more aggressive disease. And that has been mostly characterized on an ethnic type of level. So we see it increased, that gene, or the mutation in that gene that's associated with NASH. We've seen that in Hispanic populations, Asian populations, and we see the lack of that mutation in Black populations. Okay, and so that's probably the first part of the answer to the first part of that question. The second part is hereditability has also been explored in terms of if a family has NASH and NAFLD, does a person or a patient in question also have that same risk? And that's been harder to answer. We see a signal there that there probably is something to it, but it's not across the board. And so a family with NAFLD and NASH, even though that frequency is high, we don't necessarily see it in every single person in that family. So it's not like a single gene that you inherit and you will definitely get the disease process, like let's say with like cystic fibrosis per se. It's more of just if a family has it, then you might be at increased risk for it. And that's how the familial kind of hereditability studies have played out. Even with twins, identical twins, one twin might have the disease and another twin does not, although most twins who have it, or in gene, most twin studies, one twin who has it, the other twin does. But again, it's not across the board. So it's not 100% if a family has it that somebody's going to have it.
Thank you. So is the risk for NASH the same for both men and women before women hit menopause?
Oh, that's a great question. I don't know if I know that answer precisely. The issue here is we do know that within the general population, if you're overweight, if you have diabetes, you're going to get NAFLD, and that's in men and women, and that's probably pretty equal. Really, the distinction in the sexes is probably made when we see NASH as a more aggressive variant, and I don't know if that's been necessarily shown in premenopausal women compared to postmenopausal women, or men compared to postmenopausal women. So I don't think that's been shown.
Okay, thank you. Someone's asking about pediatric NASH. I think it's good to touch on, if you could just touch on it quickly. What is the current landscape and the future?
Yeah, I will admit to you, I don't know too much about pediatric management. My assumption is the physiology is probably the same, right? So overweight, diabetes, and if a child has those things, which unfortunately we're seeing increasing rates of, then they're going to have increasing rates of NASH and NAFLD. What I've seen is in certain types of liver diseases, if they are presenting at an earlier age, they tend to be more aggressive by the time they hit adulthood, as opposed to someone who develops that disease as an adult. And so potentially we might extrapolate or theorize that kids with NAFLD and NASH might potentially have more aggressive disease. But again, there's some selection bias in the way I'm answering that question. So I would say in terms of how the disease plays out, it's still important to think about it kind of categorically the way I've outlined it, that There is going to be kids with just plain fat in the liver, and there are going to be kids who develop more aggressive disease variation, and the ones who develop who are at risk for more aggressive disease are probably the ones who are, more obese, the ones with diabetes. And if they're already presenting with high blood pressure as a kid, if they're presenting with cholesterol derangements as a kid, then those are going to be the ones that probably develop NASH, or if not in childhood, then certainly by the age of their adult. Management of it is going to be tougher because medications that we use in adults are not always used or studied in children, or if they are, they're studied kind of after the first release with the adult trials. And so I don't know what the state of pediatric NASH medications testing is. I think the best bet for treating NASH in a child is going to be weight loss, because then not only are you treating the NASH, but you're preventing all of those problems in their adulthood. So you're preventing heart problems, you're preventing diabetes, etc. And so the weight loss treatments for children really should be lifestyle. Surgery, I think, is being explored in children at certain centers, and so that's potentially consideration, but that's controversial. And then endoscopic and medical weight loss, those are much more limited just because it's not been studied. That's not to say it won't be studied by pediatric gastroenterologists and hepatologists in the future, but right now we just don't see enough data for me to answer that question on a broader scale.
Okay, thank you. Okay, in the interest of time, we're going to go ahead and wrap up. But any other questions? I know there are still many questions that need to be answered, so I will work with Dr. Pham to get those answers to you. I want to thank you again, Dr. Pham and David, for your time. Thank you to Intercept Pharmaceuticals and GenFit for supporting this webinar, and thank you for everyone for joining us today. Okay, with that, I'd like to bring this webinar to a close. Thank you all so much for participating today.
Thanks, everyone.